So one of the things that we learned from the Collor Trial was that the adding of systemic chemotherapy to women, especially those that have estrogen receptor negative local regional recurrences, conferred a great benefit to that patient population. We could not say the same for patients who were estrogen receptor positive, but there was a dramatic benefit to the administration of a course of chemotherapy to those women who were estrogen receptor negative, with a decrease of approximately 70% improvement over the patients who did not receive chemotherapy in terms of disease-free survival and breast cancer-free interval. Now, I'd like to highlight some of the details of the Collor Trial, which was unique. It was a pragmatic trial where the investigators, the institutional investigators, selected the chemotherapy that the patients were to receive if they were randomized to that arm. And in that fashion, we think it was a very pragmatic trial, and it is of great importance that, given those conditions, that the retreatment of patients with another adjuvant course of chemotherapy showed as much benefit as it did. Now, one of the other important aspects of the Collor Trial is that women who presented with estrogen receptor positive recurrences were mandated to continue to receive endocrine therapy. And usually this meant that there was a switch to the endocrine therapy, because by far most of the recurrences that we saw in our patient population, patients were not receiving any active therapy at the time of their recurrence. The rationale behind the Collor Trial is derived largely from an analysis, a retrospective analysis of NSABP trials, where we looked at a total of 5 node-negative trials and 5 node-positive trials, most of which were conducted in the 1980s and 1990s. And we looked at that patient population and saw that patients who developed a local regional recurrences, and we looked at the subset of only lumpectomy treated patients. So these were patients who either recurred within the breast or the soft tissue of the chest wall, or the nodes, usually in the axilla. And we learned from those trials, both for node positive and node negative patients, that those that developed a recurrence had a much worse disease-free and overall survival in the 5 years following their recurrence. And that was the basis, in part, for the Collor Trial, as well as other institutional series that have been previously published. So it's many investigators recognized, and many physicians around the world, that the occurrence of a local regional failure event was a poor prognostic indicator. And that in general, we've known this also since the first analysis of the earliest of the NSABP B06 trial, which was a trial that compared breast conserving surgery to mastectomy, that the notion that the patients who had an in-breast recurrence did worse overall than those that didn't have a recurrence, and that recurrence was that it was a prognostic indicator, not an instigator of the distant metastasis that would be seen later. So the NSABP, together with the International Breast Cancer Study Group and the Breast International Group, joined forces to conduct the trial that is now known as the Collor Trial. And the Collor Trial was designed in a way to be a pragmatic trial, The reasons for this is that we wanted to capture as many patients as possible, and we realized that patients would have been treated with different types of regimens in the past, specifically chemotherapy regimens. So it was very difficult to find a single regimen that we thought would be suitable for future patients that would suffer a recurrence. And we felt that the question of chemotherapy was a very important question to ask. And so therefore, chemotherapy was the randomization, and we mandated that patients who were estrogen receptor positive receive endocrine therapy, just as it is common practice to do. Now, in terms of the issues of the local regional treatment for local regional recurrence, the Collor Trial mandated that the tumor be excised and that radiation therapy be selectively administered to patients after surgical excision. And what I mean by selective is taking into consideration whether that patient had already had radiation. For instance, if they had a prior mastectomy, if they had already radiation, if they already had post-mastectomy radiation, then the investigators were guided to to radiate a smaller area, or just consider a boost to the tumor bed. Since 2014, I believe that more and more oncologists have adopted the findings of the Caloric Trial, and that chemotherapy is being used for women who develop an estrogen receptor negative local regional recurrence. I think it's difficult to gauge worldwide how, to what extent the findings of the Collor Trial are being implemented. To this date, the Collor Trial continues to be unique in terms of, as far as I know, is the only prospective randomized trial that has addressed this question with, positive findings. And what's reassuring is that as we first presented the 5-year data, and now with longer follow-up, with a median follow-up of 9 years, we can say that the data hold up, and that administration of chemotherapy for ER-negative local regional recurrences is associated with a very significantly improved disease-free survival and breast cancer-free interval. So I think that's one of the toughest questions you can ask, is because there's so many presentations at this meeting and so many posters, and therefore a lot of valuable data. We're going to be hearing a lot more about immune therapies and understanding the interface between cancer and immune response, and this is a very new, exciting field that there are many researchers around the world that are investigating, and I think over the next few years, as we already have several immune therapies that have been shown to be valuable in metastatic breast cancer, so I think there will be more to come. I think there will also be some presentations, for instance, about even doing less surgery for breast cancer patients, such as whether patients with minimal disease in the axilla require any surgery at all. In the past, surgeons have held on fiercely to performing nodal surgeries, sentinel node biopsy, nodal staging procedures, and it's possible that in the future this will be eliminated. There will be a presentation about that tomorrow.